Okay, this cannot, it is not highlightable like the
Yeah.
previous one.
Mm-hmm.
Okay,
It's weird.
no problem.
Mhm.
67-year-old woman, Hodgkin lymphoma, is being prepared for discharge after treatment of hypertensive crisis. Currently receiving first course of chemotherapy. 1 year ago, she received pneumococcal and influenza vaccine. Blood pressure has responded to lisinopril. Temperature normal, pulse 80, respiration normal, BP 140/80, an enlarged supraclavicular node. The spleen tip is palpated at, sorry, splenic tip is palpated at 5 centimeter below the left costal margin. Administration of the administration of which of the vaccine is most appropriate for this patient? Okay, 67. It's a pneumococcal influenza.
Ready?
She already 1 year ago. Okay. Yes.
Mm, okay. So it's influenza. A respiratory illness that can be complicated by lower respiratory tract by pneumonia, bacterial superinfection, especially in old and immunocompromised. Symptoms include fever, chills, myalgia, malaise, headache, cough, nausea, vomiting. CDC recommends influenza vaccine beginning at 6 months. Vaccine is available in intramuscular injection or inactivated IM of inactivated virus or nasal spray, which is live. Inactivated vaccine can be given intramuscularly to patients who are immunocompromised and severe risk of illness, influenza-related complication. Influenza is a seasonal allergy affecting patients in the winter and early spring. Patients who are immunocompromised should receive vaccination, annual vaccination with the virus. Yeah. It's not pneumococcal. That was my other. Where is it? Pneumococcal 23 vaccine and is indicated for adults over 65 and in patients with high risk conditions such as chronic heart, renal, or liver failure, any chronic smoker. This patient was given it 1 year ago, so doesn't need a booster. Okay. Any other answer
No,
choice
no.
you want me? Okay, next.
27-year-old woman uh, comes to physician because of vaginal discharge and itching for 1 week. Sexually active, multiple partners for 3 years. They use condoms occasionally. Over the past 3 years, she had 3 episodes of candidal vaginitis and 3 episodes of genital herpes. A physical examination: white vaginal discharge with a cottage cheese consistency. A pap smear is obtained. Topical antifungal medications are prescribed. Which of the following is the most appropriate next step in the diagnosis?
Ready?
Okay, okay,
HIV testing is the next step.
yes.
HIV testing, most appropriate next step for this patient with high risk sexual behavior, recurrent vaginal candidiasis, and herpes infections. Routine one time screening is recommended for most sexually active patients over the age of 13, but more frequent screening is given to those with high risk contracting HIV. This population includes numerous sexual partners, especially if condoms are infrequent, patients who exchange sex for money, so prostitutes, in IV drug users, those who have HIV positive partner, and men who have sex with men. This patient high sexual behavior and high a history of recurrent candida and herpes suggests underlying immunodeficiency, as might occur with advanced HIV. As such, testing with HIV is prudent. Testing typically involves the use of fourth-generation combined HIV 1-2 antigen antibody test. If the test is positive, then further antibody testing to differentiate between infection with HIV-1 or HIV-2 is indicated. A fourth-generation test is positive, but the results of further antibody tests are negative or indeterminate, then the viral load should be measured. While genotyping is usually recommended to determine resistant patterns to drugs, antiretroviral drugs, positive HIV test should prompt immediate initiation of the ART. It's not
What is
fungal.
fourth generation test?
What is it? Fourth generation.
Is there any name of this test or it is called fourth generation? I
That
never heard this.
I don't know. Fourth generation combined HIV. Never heard. Fourth generation combined HIV 1-2 test. Mm,
Is it like a blood test?
it is like a blood test. That doesn't. I guess that's the name.
Okay. It is the
Yeah.
HIV P24 antigen. Oh,
Yeah, it's like antibody antigen test, but
oh,
it
okay.
does. I guess that's the actual name.
Okay. Antigen antibody test. Okay. Got it.
Where am I? This one. Wait, where is my? Okay. It's not fungal culture is incorrect. Vaginal candidiasis can be diagnosed without the use of fungal culture as yeast forms are readily appreciated on microscope of vaginal secretion, thereby making fungal culture unnecessary. It can be diagnosed clinically and is not colposcopy. What was colposcopy? Is indicated only if this patient pap smear discloses abnormal findings. Okay, that's for the cervix. Okay.
Okay.
Next.
6 years after beginning of dicloxacillin for cellulitis of the right lower extremity, 37-year-old woman come to ED, 3 hour history of pruritic rash, dyspnea and mild cough. Pruritic rash, dyspnea and mild cough. History of childhood asthma, no history of adverse reaction. 6 months ago, she had strep pharyngitis treated with penicillin. She has otherwise been healthy, temperature normal, pulse 110, respiratory rate normal, blood pressure is low, hypotension 80, okay. Pulse oximetry on room air oxygenation saturation is 92. Skin shows 1 to 2 centimeter of pink arctic area over the trunk, upper and lower extremity, and 3 centimeter erythematous mildly tender over the distal right lower extremity. Air movement is poor and inspiratory and expiratory wheezes are heard on auscultation. Hemoglobin 13, leukocyte 9500. X-ray no abnormality in addition to discontinuation of the dicloxacillin. Which of the following is the most appropriate next step in the pharmacotherapy? Is it anaphylactic?
Oh,
No. Res there is urticaria only. There is no respiratory distress. Oh, no. Okay, our movement is proof. Okay, anaphylactic shock. Okay,
okay, so administration of epinephrine is the most appropriate immediate step in management for this patient with anaphylaxis. Anaphylaxis type 1 sensitivity, hypersensitivity reaction develops following exposure to an allergen. In this case, it was dicloxacillin. It is caused by widespread IgE-mediated mast cell degranulation and is characterized by histamine response with within multiple organs system, leading to flushing, angioedema, bronchospasm, nausea, vomiting, abdominal discomfort, vasodilation, which can lead to airway obstruction and circulatory collapse. If not managed promptly, death can occur. The diagnosis is made clinically, and first treatment should be intramuscular epinephrine. Adjunctive medication may include Beta agonists to glucocorticoid, histamine blocker, fluid resuscitation, and potentially invasive airway vasopressor support. When meds are suspected as the cause of anaphylaxis, an allergy warning should be placed in the patient chart at the time of discharge. At the time of discharge, all patients should be provided with the epinephrine injector and instructions on how to use it. They should also be educated on the nature of their allergy and advised to avoid antibiotics within the same family. In some instances, referral to an allergist may be appropriate. Next.
Okay. A previously healthy 47-year-old woman comes to physician, 3-month history of progressively worsening fatigue. He had 14 kg weight loss during this period. Vital signs are normal within the limits. Splenic tip is 8 centimeter below the left costal margin. Hematocrit 40%, leukocyte 36,000, platelet is 70,000. Bone marrow aspirate and biopsy shows 100% cellularity with an increase in hematopoietic cell line. Which of the following is the most likely following confirm the diagnosis? Mm,
Hmm,
What is your diagnosis?
I don't know. There's some kind of leukemia.
So is it CML?
Mm, 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 mm. I guess, yeah. I know it's not ALL. I know it's not CLL. So it's either CML or AML.
Okay.
Okay. Oh, pick. Did I pick? Yeah.
Okay.
Okay. So it was, I guess,
CML.
CML. Okay. The presence of BCR-ABL fusion protein, the product of abnormal chromosome known as Philadelphia chromosome will likely confirm the diagnosis of CML. CML is diagnosed by the presence of the Philadelphia chromosome at translocation between chromosome 9 and 22, which causes constitutive activation of the ABL kinase protein. Activation of the ABL kinase leads to subsequent activation of the JAK-STAT and the other pathway, leading to increased hematopoietic proliferation, inhibition of normal checkpoint inhibition, and resistance to apoptosis. While the Philadelphia chromosome is required for the diagnosis of CML, it can also be found in ALL and AML. Typical lab findings of CML include leukocytosis with an increase in nearly all cells. But here it's not leukocytosis. Okay. Basophilia and eosinophilia are characteristics. Leukostasis, a condition in which leukocytosis leads to end organ damage from occlusion of capillaries by malignant cells is uncommon. This contrasts with ALL, acute leukemias, in which circulatory blasts, which are large and not pliable, easily lodge in capillaries, causing pulmonary and neurological complications. Treatment with CML is primarily with tyrosine kinase inhibitors such as imatinib and this whatever. Much such medication are effective and often result in complete molecular response remission within several months of its initiation. So it's not pig glycoprotein. I want to know. Pig glycoprotein is an efflux pump that belongs to the ABC class of transporters. Leukemic cells may develop the ability to actively shunt chemotherapeutic agents out of the cell using P glycoprotein, thereby rendering them resistant. However, the presence of P glycoprotein does not confer CML. Interesting. It is not T18 to C16 translocation. This is found in AML. Patients with AML have circulating myeloblasts present on the peripheral blood and the bone marrow. Okay.
Okay. A 42-year-old woman comes to physician follow-up. She had paraplegia since being involved in a motor vehicle collision 12 years ago. She had a recurrent urinary tract infection over the past 10 years. Most recent infection occurred 3 months ago. No abnormality other than paraplegia. Occult blood is negative. Labs show hemoglobin 8.7, low MCV maybe normal, leukocyte count normal, and platelet count normal. So hemoglobin is 8.7. Which of the following is the most likely cause of this patient's decreased hemoglobin concentration? She has only paraplegia and recurrent urinary tract infection, isn't it?
Mm-hmm.
What causing this low this fall not fall into the six origin. Okay.
Cytokine-induced erythropoietin deficiency. Cytokine-induced erythropoietin is the most likely cause of this patient normocytic anemia, which is commonly referred as anemia of chronic disease. Okay. Anemia of chronic disease or ACD is common in patients with rheumatologic disorders, renal disease, malignancies, and chronic infections, as in this case. Chronic inflammation with release of inflammatory substance such as interleukin 1 and TNF alpha leads to increase in hepcidin production, a decreased responsiveness of the bone marrow to EPO, and retention of iron within the reticuloendothelial system. This confluence of factors leads to impaired iron absorption and recycling, with a consequent state of functional iron deficiency despite adequate iron stores. Okay. Iron that is retained within the reticuloendothelial system cannot effectively be accessed for use in erythropoiesis. So patients present with either normocytic or microcytic anemia and reduced number of reticulocytes indicate inadequate bone marrow response to anemia. Other lab findings include normal to slightly increased ferritin concentration, which is the storage form of iron, with decreased serum iron concentration and a decreased TIBC. Treatment must focus on treating the underlying disease and decrease inflammation. Okay, and it's not.
In anemia of chronic disease, serum ferritin is only high, isn't it?
Mm-hmm.
So, okay.
And it's not myelodysplasia. Myelodysplasia describes a genetically diverse set of disorders of the bone marrow that affect multipotent stem cells of the bone marrow. Affected cells may expand and displace other cell precursors, leading to anemia, neutropenia. Everything is low. In some instances, patients um, may
AML.
develop acute AML here. This condition is uncommon in people under age 50, and isolated anemia in the absence of other cellular abnormalities will be atypical. Okay.
Okay.
Oh, it's not, sorry. It's
Yes.
not it's not G6PD deficiency. It can lead to hemolysis on the condition of oxidative stress, as the enzyme is required to produce NADPH for the reduction of glutathione, which scavenges reactive oxygen species in erythrocyte. Hemolysis here present with anemia and increased indirect bilirubin. Okay, got it. Next.
Okay. 32-year African American iron deficiency anemia comes to the office for follow-up. He has had adhered to medication regimen to ferrous sulfate, which he has begun 6 months ago. No bloody vomiting in the stool or urine. Smoke a half pack of cigarette daily for 10 years. Drinks 12 oz beers on weekends. Vitals are normal. There is no conjunctival pallor, no abnormality. Lab show 6 months ago hemoglobin 10.7, now hemoglobin 10.9. Hematocrit is pretty similar, 30 to 33. Erythrocyte is 5,000,000, 4.8. MCV is 70 to 72. Leukocyte count is all right. Okay. Platelet count is slightly low today, like 205,000. Our red cell distribution width is within the normal range. Blood smear microcytosis and target cell at 6 months ago. Now there is microcytosis and target cell. Serum iron is 60 and 75. Is iron is normal level? Isn't it in the normal range?
Let me see. Iron, male, normal is 65 to 175. So
So
he,
both are normal range.
okay.
So iron and transferrin saturation both are normal. Most
I guess it's normal
most
now. Wait, what was the MCV is low? Is it?
yes, MCV is low. It is 80 to 100. There are multiple areas. Okay, 80 to 100 is yes, MCV is low.
Where is it? MCV is low. But okay, the erythrocyte, the hemoglobin is low, but the erythrocyte count is normal. Have you noticed that?
Erythrocyte count is normal. Yes,
Yeah, but the hemoglobin is low, right?
yes, hemoglobin is slightly low. Yes,
Mm.
even if he is getting the iron is not corrected as it should be, isn't it?
Is not iron is not corrected as it
10.7 6 months ago after getting the ferrous sulfate for the 6 months, only zero point 0.2 hemoglobin is increased.
mm, okay. No, the iron is good because the iron now is good. 75 is good. Red blood cell aplasia, thalassemia.
Okay, awesome. Okay,
Okay. Ready?
yes.
Okay.
Apart from thalassemia, nothing makes sense. Okay,
Yeah. Thalassemia is most likely diagnosis African American patient with microcytic anemia and a normal red blood cell distribution, and the normal iron study that hasn't changed despite several months of iron therapy. Thalassemia is an inherited condition in which one or more alleles of either the alpha or beta globin genes is rendered non-functional, thereby interfering with normal synthesis of hemoglobin A. Okay, the normal adult hemoglobin consists of two alpha globin subunits and two beta globin subunits, in which together they form alpha 2 beta 2 hemoglobin A, a unique conformation that has high affinity for oxygen in the lungs and can offload oxygen effectively in the peripheral tissues. In patients who have one or more deficient beta globin genes, beta thalassemia major or minor, the normal hemoglobin A molecule cannot be made, and the excess alpha globin chains combine with one another to form insoluble tetramers. There are four alpha globin alleles, and the severity of alpha thalassemia depends on the number of these alleles that are non-functional. Many patients with alpha thalassemia trait are asymptomatic and only exhibit minimal decreases in hemoglobin concentration, although microcytosis is frequently encountered. Patients with more non-functional alleles present with increasingly severe levels of anemia. Microcytosis and the presence of target cells on peripheral blood are characteristic for both alpha and beta thalassemia. Okay. These two conditions can be reliable distinguished using hemoglobin electrophoresis. Patients with thalassemia trait and thalassemia minor are often incorrectly diagnosed as having iron deficiency anemia. And in these instances, oral iron therapy will have no effect on the hemoglobin concentration. Oh, got it. Transferrin saturation of 18 to 20% is often used to exclude iron deficiency anemia. Okay,
okay.
next.
23-year-old man with sickle cell disease comes to ED, low back pain for 12 hours. During this time, he had nausea, decreased intake of solid and liquids, pain rate 8 out of 10 on pain scale, taking ibuprofen every 8 hours with no relief of pain. He appears to be in distress, vitals are normal, pale conjunctiva, hemoglobin 7.2, BU when 32, and creatinine is 2.6. In addition to administration of oxygen and 0.9% cell line, the most appropriate next step.
Ready?
Should we go for opioid as
Probably. And
pain is
it probably
pain
has to
is
be.
very high?
Probably has to be IV either way because he cannot drink anything. Yeah. Um. Okay, so it was IV morphine. Okay.
So
IV morphine.
what you have given, like IV morphine?
Uh-huh. Uh-huh.
Okay,
IV
okay.
morphine. IV morphine is the most appropriate medication to administer to this patient who is experiencing acute painful episode. Vaso-occlusive and oh, I forgot here sickle same. Yeah. Vaso-occlusive phenomena are common in patients with sickle cell disease in acute painful episodes, sometimes referred to as pain crisis, are one manifestation of vaso-occlusive symptoms. In children, pain is often concentrated in the hands and feet, but pain can also develop in the abdomen, back, chest, and long bones, among other locations. Rapid assessment of the patient is critical to determine if there are other concomitant disorders that accompany the acute painful episode, including acute chest syndrome, MI, venous thromboembolism, or infection. However, further diagnosis should not delay the administration of analgesia, which should generally be an opioid. The rapid administration of analgesia is so important that at many centers, patients with sickle cell disease have an individualized and predefined pain pathway that can be given to physicians to aid in rapid and complete treatment of pain. As a result, chronic exposure to opioid is common for patients with sickle cell to require substantially higher doses of opioid medications than what would, what would be expected in normal patients. Reversal of inciting features such as hypoxia, hypovolemia, acid-base disturbance, and infection should be prioritized as well. It is not C. I wanted to know why it's not C.
Can you read the option of the D?
Yeah, it's not intramuscular ketorolac is not preferred treatment for patients with acute painful episode. It is unlikely to produce the required level of analgesia. Additionally, this patient has been using medication of an identical class, the NSAIDs, on a schedule without relief. And it's not IV meperidine, while an opiate, okay, is rarely used for treatment of acute pain. And if it is, it should be given IM, not IV. Its pharmacodynamics and kinetics make this use challenging, and it has been replaced by newer and more predictable, reliable engines,
So
meperidine.
if it is IM, is there any way of giving IM meperidine? Like meperidine and morphine both are opioid, isn't it?
Mhm.
So they are talking that in acute pain we should give intramuscular, not intravenously,
No,
because
no, that's not what it is. That's not what it is.
okay. Can you explain the option D? Hello?
Can you hear me?
Yes, now there is
I
something happened like call is held.
oh,
I don't
but
know
now
what.
you hear me?
Yes, and now I can hear you. Yes.
Oh, they're saying for acute pain, meperidine is only given IM, not IV.
In acute pain, meperidine is given in IM, not IV. So
Hmm.
meperidine can be given.
If there was no morphine, yes, I guess you will give meperidine. But if there is another opioid in the answer choices, don't give meperidine. That's what they're saying because it's difficult to control.
Okay,
Mhm.
okay, got it.
Okay, next.
A 72-year-old man comes for routine examination, 20-year history of poorly controlled hypertension with frequent diastolic pressure 105. He smokes 15 cigarettes and 3 glasses of wine daily. His father died of cerebral infarction at the age of 58. Blood pressure 150 by 105. Fasting blood glucose 180, LDL 170. Which of the following is the greatest risk factor for cerebral infarction in these patients?
That one you should know. What is it?
Hypertension.
Okay. Hypertension is
You need to
considered.
sit on my back and say yes.
That one, if you tell me you missed that one during the exam, I'm gonna be like, hypertension is. I feel like this is like in all the like one question similar. It's like in all the exams that we take. This is a similar question. Hypertension is considered
But
the great.
don't fall in the trap. Like they will change it.
They would say, even if fine, they change something and you pick hypertension, I'll still be fine. But if you see this and you pick something else and it was hypertension, I'll be like, no, man, no, please. No.
Okay.
Hypertension is considered the greatest modifiable risk factor for cerebral infarct and is an important contributor to the development of cardiac and renal failure and atherosclerosis disease. Okay, cardiac renal failure. Okay. Uncontrollable hypertension is associated with an approximately twofold increase in the risk of ischemic stroke. Additionally, this risk is incompletely eliminated even when hypertension is well controlled. Oh, in this patient, initiation of antihypertensive therapy is an important component of stroke prevention, as well as lifestyle modification, including weight loss, diet modification, smoking, stopping smoking, and regular exercise. Okay,
Why
next.
smoking is the risk factor?
What do you mean?
Like option E. Can you read the
Oh,
option E?
option E. Where is it? Right here. Smoking history is an important and modifiable risk factor for ischemic stroke, though the relative risk for less than that
Is
of
there
hypertension.
anything like AAA or TAA? Smoking is the most important risk factor.
For
There is
AAA,
something in
yeah,
AAA, abdominal
it,
aortic aneurysm.
I
Cigarette
think
smoking is the most important risk factor, not
I know for
hypertension.
sure. No, yeah, not hypertension. No, I know for sure. I think is the MI is smoking, and I think AAA is smoking too. Yeah.
AAA is smoking. Okay,
Mhm. I think so.
these are a bit
Okay.
confusing.
Mm,
Okay, 70-year-old woman, severe degenerative arthritis because of 2 week history of ringing and pain in her ears. She has no other serious illness. She's taking aspirin, acetaminophen with minimal relief. Examination of the shoulders and knees shows no swelling. Active range of motion elicits pain bilaterally. Which of the following is the most likely in this patient? Ringing. Is it the aspirin and like salicylates causing something?
you think so?
Because there is ringing, aspirin or salicylate, this toxicity can cause ringing or pain,
Okay.
isn't it? I don't
I
know. I
mean,
am talking.
I mean, it's the only thing that makes sense, but it doesn't say that she has. I guess she has been taking it for a while. I thought she had just taken it for a short while, but I guess yeah, that's the only thing that makes sense. So it will be pH will be what, acidic, so it will be
Acidosis,
less.
isn't it? Salicylate. Salicylate has
Yeah.
both like acute and chronic. There is a problem.
What do you? Uh huh.
Salicylate toxicity. It has both acute and chronic.
Oh,
Like normal anion gap metabolic acidosis may be acute.
so it will be. It will be. The
And
first one will be the
and there is another like respiratory alkalosis, isn't it?
respiratory alkalosis will be the first one, which will show.
Respiratory
Which will
alkalosis is the acute one. The chronic one is the metabolic acidosis.
acidosis, then
Okay.
for bicarbonate will be low, so less than 22.
pH should
So
be
they cannot be,
low.
it cannot be this, and it cannot be this. Okay, and then chloride, where am I? Bicarb is low, so pH will be 7.2. pH.
pH is quite
pH is
uh,
7.35. 735, 720. pH will be normal, right? Because it's a mix, or no?
it,
Or would it be?
it is metabolic acidosis. So in metabolic acidosis pH would be low.
But
Isn't
since it's a mix, respiratory and metals, shouldn't it be like normal or no?
low.
Am I wrong?
Sorry.
Don't follow me. I don't know. I don't know. I'll probably be getting it wrong.
I think
Ready?
wait 1 second. 1 second.
Mhm.
Okay.
Okay. The answer is C. pH is normal. Okay, then I was right on that one. Aspirin is an antiplatelet agent that irreversibly activates COX, which, no, it inactivates COX, which prevents the conversion of arachidonic acid to thromboxane 2. Thromboxane 2 is involved in platelet activation, and its decreased synthesis results in platelets, in reduced platelet activation. Beyond its effect on platelets, salicylate poisoning in large doses results in respiratory alkalosis. We knew that from the stimulation of the respiratory centers, hyperventilation, so CO2 will be low. Subsequently, it results in the development of delayed anion gap metabolic acidosis. We know that secondary to whatever the coupling effects on the electron transport chain, resulting in decreased anaerobic it increased anaerobic metabolism and the production of lactate and ketoacid. It does not typically affect the sodium and potassium. Okay, that's where we were confused. In major ways, patients with acute salicylate toxicity will present with hyperventilation. Okay, we know GI upset, hyperthermia, tinnitus, agitation, delirium, and hallucination. Patients with chronic salicylate ingestion may present with identical symptoms to acute toxicity or with mild symptoms of tinnitus, nausea, vomiting, diaphoresis. Mild toxicity may present with an increased anion gap and a compensated metabolic acidosis, as in this case. Hmm. Management of acute or chronic salicylate toxicity involves systemic alkalinization with sodium bicarb infusion. Patients may need dialysis in the setting of severe arterial metastasis, renal failure, pulmonary edema, or clinical deterioration. You got it?
Why not B?
B. Let me see. What is it? B. 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 Okay. Salicylate poisoning will be unlikely to cause hyponatremia, hypokalemia, or hyperkalemia. Hyperkalemia commonly occurs in renal insufficiency, aldosterone deficiency, or renal tubular acidosis. Salicylate toxicity results in anion gap metabolic acidosis secondary to the production of lactate and whatever, and will not result in normal or increased bicarbonate concentration. Huh.
Okay.
While patients may have respiratory, oh, that's it. Okay, you said
So
this.
main theme is like salicylate poisoning cannot cause hypokalemia. Like
Yeah,
option B is potassium is 3.2, so it is hypokalemia.
yeah. The main thing
Hypokalemia
is
or
that salicylate.
hyperkalemia. Yes, yes.
Yeah, the main thing here is that it does not affect sodium and potassium. So sodium and potassium level would be normal. It only affects bicarb, and then the pH will be normal because it's a mixed respiratory alkalosis and metabolic. Both are mixed, so the pH will be normal. So here the pH I think is it low? Here I'm not sure. Seven
No,
and
no,
it's
pH
in
is normal.
normal. Okay, yeah. So yeah, I guess the point is just bicarb is affected, pH is normal, none of the other things are affected, none of the other electrolytes.
Okay.
Okay. Mm.
23-year-old woman comes to the physician because of lesion on her lip that appeared 1 day ago. She reports feeling a tingling and burning sensation in the same area for the past 4 days. Examination lower lip shows a grouping of discrete clear fluid or filled vesicle that are 5 millimeter in diameter. Which of the following is the most likely diagnosis?
Hmm.
Is it cold sore?
Kind of look like tingling and burning sensation in the same area for the past 4 days. Hmm. I don't know why. Okay. But she's 23, so can she have herpes zoster? She's that young, or is it
Uh,
chickenpox?
Herpes zoster is like unilateral. Tingling, burning can happen, but it can be unilateral.
Unilateral,
Unilateral, not in the lip. In
not
the
in the lip. Usually.
Yes, in the
Yeah.
lip, like herpes labialis, this type of thing,
Okay, so it's something
isn't it?
simple. I think. I mean, I yeah. It's just that because they're saying that there was the burning that
According
came
to
before.
according to Sketchy, the kissing disease.
Yeah, you're right. Okay, let's go. Uh, then
Okay.
yeah. Right. Herpes HSV, herpes simplex infection commonly causes oral infections known as herpes labialis that typically begins with the formation of vesicles at the oral labial margin, which lies and progresses to shallow, painful ulcers with a red base, with a red border. Many patients experience prodromal symptoms of burning, tingling, itching. Oh, okay, or pain for several days prior to the appearance of the vesicular lesion. Herpes labialis is most often caused by HSV1, but can be by HSV2. For infection with both strains is possible. Following initial infection, HSV may be latent in the trigeminal ganglion until reactivation, when it causes painful vesicles and punch-out leaf erosions on the lip with associated lymphadenopathy. Reactivation may be triggered by stress, sunlight, or local trauma, such as dental procedures. Diagnosis is confirmed with viral culture and PCR tests from the base of the lesion if uncertain. Treatment includes antiviral agents that inhibit viral DNA polymerase, um, classically by guanosine analogs like cyclovir, valacyclovir, famciclovir, chosen based on the severity and recurrence of presentation. So changes may shorten the duration of an outbreak. Okay, it's not chickenpox and it's not herpes zoster. Chickenpox is caused by primary infection with varicella zoster virus, also known as HHV3, and herpes zoster, which is transmitted via respiratory secretions and direct contact with infected skin lesions. It most commonly presents in childhood with diffuse pruritic asynchronous rash with fluid-filled vesicles that cross. Chickenpox does not present with localized vesicular lesions in the oral labial margin. Reactivation VCV may present with shingles, manifesting as multiple vesicular lesions in a unilateral dermatomal distribution when localized. Okay.
Okay. Can we take a can we take
Yeah.
5 minute break? Yes. Yes. Yes.
Better.
Now.
Okay.
Looks like so. Okay. Otherwise healthy 42-year-old man comes to the physician, 3-month history of progressive rash over his arms and back. The rash is mildly itchy, temperature normal, pulse 72, respiration 16 per minute, blood pressure 115 by 80. Photograph of the rash is shown. Which of the following is the most likely diagnosis? What is your diagnosis?
I'm between psoriasis and tinea corporis.
Why it is tinea corporis?
I
Tinea
forgot how was it
corporis is extremely itchy, very itchy.
extreme. Okay, then it's probably psoriasis.
And in the psoriasis, there is silver scaly lesion, and in the tinea corporis, there is central clearing.
Central hearing.
Clearing.
Central hearing. Okay. Ready?
Yes.
Where am I? Okay. So psoriasis, a common inflammatory skin condition caused by immune dysregulation leading to keratinocyte proliferation. Psoriasis has a variety of presentation, the most common in which is a plaque psoriasis, also known as psoriasis vulgaris. Plaque psoriasis presents with multiple sharply defined red cutaneous plaques with white scale commonly appearing on the extensor surfaces. Although they may present diffusely over the body, the lesions are commonly pruritic. Um, Removal of the white scale causes pinpoint bleeding, which is also called Auschwitz sign. Patients may also present with nail changes, most common nail pitting. Other forms of psoriasis include pustular psoriasis, psoriatic arthritis, and goutte psoriasis. Treatment of psoriasis include topical therapy such as steroids and vitamin D analogs. If the psoriasis is refractory to topical therapies, then phototherapy, methotrexate, and biology medications may be considered. It's not atopic dermatitis, which is eczema, has a varied presentation depending on the age of the patient, though generally lesions may be identified in flexure creases or on extensor surfaces and are often excoriated and liquefied. Atopic dermatitis often present in patients with a history of allergies and asthma, and is not, what was the other one?
Your tinea.
Leotinia corporis. Yeah. It's not tinea corporis. It's caused by dermatophyte infection of the skin, most common trichophyton tonsurus. The classic appearance is round annular patch with a scaly border. KOH will discuss why numerous plaque are not typically seen, so non-numerous plaque. Round with patchy. Okay. What else am I confused about? Okay. Okay, never mind. That's it. Next.
57-year-old man comes to the physician, 12-week history of left shoulder pain, radiate to the middle of the left upper arm, radiates to middle of left upper arm. He is awakened at night by pain when he rolls on the affected shoulder. He does not recall any recent history of trauma. He has no history of serious illness, takes no medication. Examination shows no muscular atrophy. There is tenderness immediately lateral to the acromion. Active abduction of left shoulder is limited to 120 degrees without resistance. and difficult with minimal resistance. Peripheral pulses normal. X neurologic examination show no local finding. X-ray of the left shoulder shows no abnormality. Which of the following is most likely diagnosis?
Ready?
Okay,
Okay, so it's rotator cuff tendinitis. The rotator cuff is a group of muscles and tendons that act to sit the humeral head directly into the center of the glenoid during motion of the shoulder. These muscles also act in concert with other muscles about the shoulder to internally, externally rotate, adduct the shoulder. The muscles include the subscapularis, teres minor, supraspinatus, and infraspinatus. Rotator cuff tendinitis is a common cause of shoulder pain in adults. Pain most commonly occurs with overhead activity that involves raising the affected arm and commonly occurs at night, especially while lying on the affected side. Athletes that perform overhead motions, such as swimmers and baseball players, may experience pain that limits their ability to participate in the sport. Diagnosis is based on clinical presentation with a careful examination of careful assessment of rotator cuff function. The affected muscle or tendon insertion is often tended to palpation. Oh, okay. X-ray is generally unrevealing, although ultrasound and MRI are sensitive for the detection of tendinopathy. Initial treatment of rotator cuff tendinitis include rest, ice, NSAID, and physical therapy. It's not accessory nerve palsy results in paralysis of the sternocleidomastoid and trapezius muscles on the affected side. Dropping of the affected shoulder may be drooping, sorry, of
Droop.
the affected shoulder may be
Mm,
present.
okay, can you read the option E?
E, yeah. Where am I? E. Suprascapular nerve palsy commonly occurs because of compression of the suprascapular notch and results in paralysis of the infraspinatus and supraspinatus muscles with resultant weakness of shoulder and external rotation and abduction. Okay. While shoulder pain is common, muscle atrophy is often present. Tenderness to
In
palpation
here,
of the
muscle atrophy is absent. Okay.
yeah. Tenderness to palpation of the lateral shoulder is atypical of suprascapular nerve. And it's not acromioclavicular separation, usually occurs following direct trauma to the shoulder and is often accompanied by shoulder deformity that is easily detected on clinical exam and
In
by
rotator cuff tendinitis and in rotator cuff rupture, can you tell me the difference? In ten,
oh
yes,
one has pain, the other one has weakness.
yes, the rotator cuff tendinitis has pain, and the rotator cuff rupture has weakness.
Okay.
And you can, like in rotator cuff, there is pain with abduction and external rotation. In the suprascapular nerve palsy, there is pain on abduction or external rotation too. But the difference, I think that in suprascapular nerve palsy there is like atrophy is present, but in rotator cuff tendinitis there is no atrophy.
Okay.
Okay.
Okay. Next.
67-year-old man comes to the office because of 3-day history of moderate pain, swelling of the right knee. He has not sustained any recent trauma. He has hypertension, hypothyroidism. Medications are lisinopril and levothyroxine. He is at 178, 5 feet 10. Okay, 178 centimeter tall, 91 kg, BMI is 29, temperature normal. Temperature is 100. Pulse 84, BP normal. Examination of the right knee show erythema, warmth, effusion. There is tenderness to the palpation of the lateral joint line. Tenderness to the palpation of the lateral joint line. Active range of motion of the right knee is limited by pain and X-ray of the show. Chondrocalcinosis. Which of the following is the most likely mechanism of this patient's conditions? Chondrocalcinosis, pseudogout.
Ready?
Yes, ready. It is pseudogout, isn't it?
Yes. Pseudocard is a type of crystal arthropathy caused by the position of calcium pyrophosphate dehydrate (CPPD) crystals into joints and surrounding soft tissues. Crystal deposition provokes an inflammatory response, leading to classic presentation of joint redness, effusion, calor, a reduced range of motion. So the gut most commonly affects the knee. Acute monoarticular arthritis has broad differential, including gout, pseudocard, osteoarthritis, trauma, septic arthritis. In addition to clinical history and examination, imaging studies and analysis of synovial fluid obtained by electrocentesis can assist in making the diagnosis. The presence of chondrocalcinosis in this patient, which refers to calcification of the articular cartilage, visualized by X-ray, is commonly associated with CPPD crystals of pseudocap. Definitive diagnosis requires identification of CPPD crystals in synovial fluid, sample of biopsied tissue, and D and E. Give me a second. D E. Infection of the joint space with gram-negative and gram-positive cocci. Gram-negative Rori and gram-positive cocci describe septic arthritis. It is generally acute and painful, often associated with fever, signs of systemic inflammatory response. The most common culprit is Staph aureus. The affected joint has pain, effusion, and redness. Arthrocentesis is characteristically purulent and discloses leukocyte more than 50,000. Okay, got it. Next.
Yes.
Next.
50, a 57-year-old man comes to the physician because of 1 week history of painful mass of the right arm. Painful mass of the right arm that developed after he lifted severe heavy boxes. He is right-handed dominant. There is no other history of the trauma to the arm. He has 5 year history of chronic right shoulder pain. Otherwise asymptomatic. Smokes 2 packs of cigarettes for daily for 30 years. Temperature normal, a 2 to 3 centimeter mobile mass palpated on the anterior aspect of the right upper extremity. There's pain on forward flexion of the right shoulder. Active flexion of right elbow is limited. Active flexion of the right elbow is limited by pain. Elbow extension strength is full and painless. Muscle strength and a sensation in the right wrist and hands are intact. Radial and ulnar pulses are 2 plus. Plain X-ray of the right upper extremity shows a vague anterior soft tissue shadow. Vague anterior soft tissue shadow. Which of the following is the most likely diagnosis?
Section of the right extremity by pain.
Okay.
Ready?
Yes.
Is biceps tendon rupture. Patient is most likely suffering from a biceps tendon rupture following an acute traumatic injury. The biceps muscles located in the anterior upper arm arises from a long and short head originating from the intra-articular supraglenoid tubercle, long head, and coracoid process, short head. Biceps tendon inserts at the radial tuberosity. Injury to the biceps tendon or biceps muscle results in pain and upper extremity functional limitations. The major functions of the biceps are elbow flexion and forearm supination. Tendon rupture most commonly occurs because of rapid force hyperextension of the forearm with the elbow hyperextension of the forehand with the elbow flex. Oh. Risk factor for acute rupture include a history of rotator cuff tear, recent biceps tendonitis, systemic steroid use, tobacco use, and degenerative changes of aging. Tenderness and swelling occur in the area of injury, and abnormally contracted mass or retracted muscle may be palpated in the anterior compartment of the upper arm. Management typically requires surgical repair. And it's not DE, it's not the lipoma, typically present as a smooth, mobile mass palpable below the skin. Most lesions are benign, they require no treatment. Biopsy may be obtained for lesions with unusual features, and surgical removal can be performed for cosmetic and functional concerns. Malignant fibrous histiocytoma is the most common type of sarcoma in adult patients. Malignant soft tissue masses are typically painless, okay, firm and heterogeneous in texture because of areas of unbalanced growth, necrosis, and inflammation.
Okay.
Okay, next.
54-year-old man admitted to hospital, 1 week history of temperature 101, chills, shortness of breath, pain, swelling on the right knee, 20 years, smoking history, poorly controlled type 2 diabetes, metformin, using metformin and insulin. Temperature is 100.1 degree Fahrenheit, pulse 100, respiration 20, BP 110/60, pulse oximeter on the room mirror shows oxygen saturation 92%, examination, cardiac examination discloses a 3/6 hollow systolic murmur based heart at the apex. Scattered crackles are heard throughout the lungs. The right knee is swollen and tender to palpation. There is 2 centimeter ulcer on the bottom of the right foot. No surrounding erythema. Soft tissue swelling is noted. When asked about the ulcer, the patient says it is not painful and present for more than 5 months. Chest X-rays shown in addition to the right knee joint. Which of the following is the best next most appropriate next step in the diagnosis? Is it the ulcer? Important thing is the ulcer.
Mm,
Like, is it
why?
osteo? Or what? Like, which of? In addition to aspiration of the right knee joint, which of the following is the most appropriate next step in the diagnosis? So they are waiting for the diagnosis.
Step in that.
Is it
Okay.
osteomyelitis? He
Uh,
has
um,
uncontrolled diabetes. You have, and there is an
uh,
ulcer. Is they are
um,
dragging on that, or is it different thing?
I'm between
I'm
A, B,
between
and F.
I'm between B and C.
A, B, and F. Because he has heart issue, blah, blah, blah. And then lungs. And then,
That won't work.
I don't know. So this one, we're going to read a lot of cancer traces because I'm
Okay.
ready.
Yes.
Okay, it's A, blood cultures. This patient presentation is concerning for bacterial endocarditis. Oh. And the most
You have
appropriate next
thought
step in
that
diagnosis
you
as
you
internal.
you thought about back endocarditis.
No, no, I thought.
As because you choose the echo.
Oh
Endocarditis.
no,
Oh,
no! I chose the echo because of the systolic. I know there was something wrong because he has a systolic murmur, so I thought, okay, let's check the heart. But you right, endocarditis, you have to check blood culture, not
blood
right
culture along with echo.
with echo. Oh, okay, yeah.
Like fever, if you find a fever and new onset murmur, the next thing you
Uh-huh.
need to do the culture and the echo. Initially
Okay.
transthoracic. If transthoracic you fail to see the mm, you fail to see the embolus, then you should do the transesophageal echo. That's how we
But
approach for infective endocarditis, i.e.
So is it the echo before the blood culture or the
No,
blood
no,
culture
again,
before the
before blood culture. Blood culture is first, then the
okay,
echo.
so you do culture video. Okay. This patient presentation is concerning for bacterial endocarditis, and the most appropriate next step in diagnosis is to obtain blood culture. Acute endocarditis is commonly caused by staph or strep. Patients typically present with fever, chills, and malaise. Extracardiac manifestation include endocardial dysfunction caused by septic emboli to the lung, as seen in this patient. As seen in the chest X-ray with bilateral scatter areas of consolidation concerning for pneumonia, and systemic circulation, vascular and immunologic phenomena such as rot spots, Osler nodes, Janeway lesions on the pans and soles, along with conjunctival and subungual splinter hemorrhage. Purpuric lesions may be noted elsewhere on the skin examination. Distal sites may be seeded with infection, as with patients likely septic arthritis of the right knee. Significant disruption of the heart valves can cause acute heart failure, as seen in this patient, with progressive shortness of breath, pulmonary valves, and X-ray of the chest disclosing pulmonary edema and vascular congestion. Potential bacterial sources leading to infective endocarditis include procedures that may disrupt mucocutaneous surfaces, such as dental procedures or cystoscopy. It's not B, bone biopsy. Why is it? Why do I say B? No, never mind. It's not C because culture of the ulcer tissue is unlikely to provide further information in this patient with poorly controlled diabetes. Skin and wound cultures are often polymicrobial with common skin infections, and skin and environmental flora and do not provide useful information. For antibiotic selection, is not F. Where am I? Where is F? It's not F because transthoracic echo and or transesophageal echo should be performed as soon as possible for this patient to evaluate for vegetation and valvular dysfunction. However, it should not delay collection of blood cultures and prompt administration of antibiotics. Okay, so you collect blood culture, you give antibiotics, and then you do the echo.
Yes.
Next.
You have to take blood culture from three different sites
Okay.
in infective endocarditis. Okay. 78-year-old woman admitted to the hospital, 2 hours history after sudden onset shortness of breath, palpitation, dizziness, hypertension, heart failure with diastolic dysfunction, medication lisinopril, metoprolol, hydrochlorothiazide, and aspirin. Temperature normal, pulse 150, irregular, respiration is 28. Blood pressure 82/50, pulse oximeter 50% oxygen saturation by NRB mask, mm, and oxygen saturation is 88%. Crackles are hard, one third of the way up in the lung fills. There is inspirator and expirator wheezing. No edema, peripheral edema is noted. ECG show atrial fibrillation with a ventricular rate more than 160 per minute. Which of the following is the next best? Should fibrillation of the ventricular rate. Sh- Should we give the rate controller? Or what? Okay. mm, uh,
Ready?
Yes.
So the answer is electrical cardioversion. This patient is presenting with hemodynamically unstable tachyarrhythmia and should be managed with immediate electrical cardioversion. AFib is a common acute and chronic condition encountered in clinical and hospital settings resulting in uncoordinated electrical activity and contraction of atria. While AFib can be asymptomatic, many patients may develop rapid ventricular response with pulse exceeding 120. Symptoms include palpitation, fatigue, shortness of breath, lightheadedness, angina, and presyncope of syncope. Physical exam will show an irregular pulse and occasionally may disclose signs of heart failure and heart murmurs. ECG with irregular RR interval and absent P waves confirm the diagnosis. Complications of AFib include tachycardia, induced heart failure, hemodynamic instability, and left atrial appendage thrombus formation with subsequent potential embolic stroke. Treatment includes heart rate control with beta blockers and non-dihydropyridine calcium channel blockers such as diltiazem and anticoagulant for patients with an increased risk of stroke. Determined by the CHAD score. Okay. Mentioned cardiovascular is required for patients with hemodynamic instability. It is not C, D, or E. Let me see if it's together. It's not C. Administration of amyloid at this time is not appropriate given this patient hypotension and acute heart failure. Amiodarone is a treatment option for ventricular arrhythmia as well as AFib that is refractory to other agents. So ventricular arrhythmia. It's not administration of diethyazine and administration of etzmolor are IV pharmacologic options for acute management of hemodynamically stable AFib, but should be used with caution in patients suffering from heart failure because of the risk of further decreasing cardiac output. Beta blockers, and calcium channel blockers antagonists, huh? Okay, are recommended in the acute and chronic management or AFib. Okay, and it's not placement of a pacemaker. Patients with symptomatic bradycardia should receive temporary pacing and be evaluated for placement of a pacemaker. So it's for bradycardia.
Okay,
Okay, next.
next.
Oh, it's weird. Okay.
72 uh, 72-year-old woman is admitted to the hospital because of 3-week history of progressive shortness of breath that increases with exertion. She has 20-year history of hypertension, poorly controlled hydrochlorothiazide. She takes no medication. She has smoked one pack of cigarette daily for 55 years. She's in mild distress. Her temperature normal, pulse 90, regular respiration 20, blood pressure 180 by 100. There is no jugular venous distension, peripheral. There is no jugular venous distension and peripheral edema. Crackles are hard over the lung, filled bilaterally. Crackles are hard over the lung, filled bilaterally. Hemoglobin, sorry, on cardiac examination, S3 is hard. S3 is hard. There are no murmurs. Lab hemoglobin 14, leukocyte 8,000, serum BUN is 30, creatinine 2, tropi 0.01. ECG show ECGs show echocardiography show normal heart valve and left ventricular ejection fraction is 58%. Which of the following is the most likely diagnosis? Ejection fraction is normal, isn't it? 58%.
I thought normally 60 or is it 50?
Um,
Is it? No, I forgot.
we are very confused on those things. Yes,
Good check. Normal rejection. 50 and above. So kind of normal, I guess.
normal. So S3 is hard. Is S3 isn't it the signs of heart failure?
Yeah. Ready?
Yes.
And the answer is B as in boy, diastolic dysfunction. The patient, hmm, okay. The patient's symptoms are most likely explained by diastolic dysfunction. She's presenting with evidence of heart failure given her progressive dyspnea and physical exam findings. Left-sided heart failure results in pulmonary vascular congestion with typical crackles on pulmonary auscultation and lack of peripheral edema. She has a S3 gallop and meets ECG criteria for left ventricular hypertrophy. He didn't even look at the ECG. The risk factors for left ventricular hypertrophy include poorly controlled hypertension and tobacco use. ECG discloses a normal ejection fraction, which makes systolic dysfunction unlikely. Okay, diastolic dysfunction results from impaired filling of the left ventricle caused by thickness and stiffness of the hypertrophied wall. Okay, diastolic dysfunction. Okay, the reduced preload can impair cardiac output enough to manifest as heart failure. And it's not D as in dog because left ventricular systolic dysfunction results in pulmonary vascular congestion with dyspnea and pulmonary edema. Um, okay, jugular venous congestion and peripheral edema are characteristic of right blah, blah, blah. Patients with systolic dysfunction show a reduced ejection fraction. Okay,
Why not left ventricular systolic dysfunction?
because the ejection fraction will be low, and here the ejection fraction is normal.
Normal.
Mhm.
Okay.
Next.
Okay. 57-year-old woman is brought to the emergency department 8 hours after 2 hour history of shortness of breath, substantial chest pain radiating to the left shoulder, radiating to the left shoulder. Pain is at 6 on 10 point scale. 30-year history of hypertension well controlled with lisinopril. 20-year history of hypercholesterolemia treated with atorvastatin. She has smoked one pack of cigarettes daily for 40 years. Pulse 90, respiration 18, 160 by 90. Basilar crackles are hard, and cardiac examination shows no abnormality except S4 gallop. Trop I is 3.6. Trop I high X-ray shows there is moderate cardiomegaly, teen version on anterior and lateral lead. Which of the following is the best evidence of acute myocardial infarction in this patient? Which of the following is the best of following findings? Best evidence of acute MI. Acute MI. Mm, acute mm, trauma.
Mm, 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 mm. Is it the pain pattern? Is it troponin one, or is it the ECG?
I am pain can may not be pain pattern. I think so. ECG. Like if somebody has acute MI, the first thing will okay, you give your answer. I don't know what is the right answer.
The right answer is troponin concentration. the patient the patient is presenting with signs and symptoms of ACS, acute coronary syndrome, with characteristic angina, substernal chest pain radiating to the left palm, whatever, and no specific ECG changes. Measurement of cardiac biomarkers supports the diagnosis of non of NSTEMI. Ischemic injury leads to leakage of intracellular protein, and an increased serum troponin concentration is strong evidence for active MI. Of the several known cardiac biomarkers, cardiac-specific troponin 1 is the preferred diagnostic assay because it's sensitive and highly specific test for damage of cardiomyocyte. Okay, the patient should be treated with dual antiplatelet therapy and therapeutic anticoagulation. Patient should be re-stratified using various score modelings to determine the urgency of cardiac catheterization, but will most likely will undergo catheterization between 24 hours. It is not B, the chest pain pattern as presented is consistent with cardiac angina with substernal pain that adheres to the arm, shoulder, and jaw. Other features of typical angina include precipitation by exertion or emotional stress and relief with rest of nitroglycerin. However, there are numerous conditions that produce chest pain with considerable overlap of pain characteristics. Chest pain pattern is suggested but not diagnostic of ACS. That's true. And it's not F. Where is F? Yeah. T wave inversion in the anterior and lateral precordial leads of ECG is a non-specific finding that could have a cardiac or non-cardiac cause. In general, T wave inversions are observed in states of high cardiovascular rates. Okay, so the key will be ST elevation. ST, okay.
So
Anyway,
if it is ST elevated MI, then it would be the answer.
I
Or
think I think ST would have been would have been
like
here
they are
ST.
looking for the active and acute MI, like active MI.
Acute acute
What
MI. Uh-huh.
like active means like heart is destroying, that they are trying to mean. Because in the explanation there is a word called active MI, like evidence of active myocardial infarction. So okay, I got the answer. Very confusing. Okay, 37-year-old woman comes to the physician because of progressive shortness of breath and blood tinged sputum over 7 days. Examination show jugular venous distension. There is increased S1 and high pitched extra hard sound after S2. A grade 1 by 6 low pitched diastolic murmur is heard at the apex radiating to the anterior axillary line. Which of the following is the most likely diagnosis? Fixed diastolic murmur radiating to the anterior axillary line. Which localized from
Because of jugular venous distension. Diastolic mitral regurgitation. Okay, ready?
yes,
So the answer is mitral stenosis. Mitral stenosis classically heard as an opening snap followed by diastolic rumble. Hmm. Okay. Um, Loudness over the cardiac apex and radiating to the axilla. Mitral stenosis occurs because of calcification, fibrosis of the mitral valve, impaired excursion of the valve leaflets, results in increased left atrial filling pressures and impaired diastolic filling of the left ventricle. Okay. The fixed obstruction to blood flow may manifest with left atrial enlargement and progression to heart failure, increased resistance to flow on the left side of the heart, can result in pulmonary hypertension. A history of rheumatic fever is the most common cause. Other causes include congenital defects and infective endocarditis. Treatment is through medical optimization followed by surgical valve replacement if severe. Okay, next. Omar?
yes.
Oh, okay.
A hospitalized 57-year-old man has had the gradual onset of the edema on his lower extremity during the past 4 weeks. Underwent prostatectomy for carcinoma 48 hours ago. Joe Biden has prostate cancer. Great
Oh my
for him.
God.
Yes, Gleason score is like 9 or 10, and it is inoperable metastasized to the spine.
I can't believe it just came out yesterday. You already destroyed.
I am very good at this. Like the celebrity people who had the disease, and I do it. I don't know
Oh, God.
how this type of great people do not come with the diagnosis early. I don't know.
I some doctors say that not all prostate cancers are like will
He,
elevate the PSA.
sorry,
Like I don't know, some doctors were commenting on it and they were saying that it's not all forms of prostate cancer that will show like an increased PSA.
don't you think that there is no other like complaints he had? It comes out in a sudden onset. Is that you are thinking about? Prostate cancer is a such cancer. You will get the clue because like in the BPH, he may have lots of problem, but he ignores his problem. Probably
Mhm.
he is very sick in the some some occasions too. He was very
Yeah,
sick,
yeah, that's true. Uh-huh.
so he ignored all his diagnosis. Okay,
Or probably, or maybe he already knew it and just didn't want to. Yeah,
yes, that
maybe.
that can happen. Yes, that can happen. Okay, we are talking like that. We are his physician.
His physicians.
Okay, as prostatectomy comes, that's why I remember. Okay, pneumatic compression stockings were applied to both lower extremities during the operation. Prophylactic low molecular weight heparin therapy was begun 24 hours postoperatively. His only other medication is morphine. His alert temperature is 100.1, pulse is 85, respiration 13 per minute, blood pressure 145 by 80. Examination of the left lower extremity show edema of the knee, of the dorsum of the feet. Peripheral pulses are normal. The remainder of the examination shows no abnormality. Venous duplex ultrasonogram of the left lower extremity show occlusion on the popliteal vein and the distal superficial femoral vein. Which of the following is the most appropriate next step? Is it DVT type of thing?
Yeah, it's probably DVT. Yeah.
Okay.
And the answer is heparin therapy. Unilateral lower extremity edema that occurs in the setting of malignancy and surgery is highly concerning of DVT, a diagnosis that is confirmed by ultrasound. DVT typically presents with lower extremity edema, redness, warm, pain at rest, along with calf pain and on dorsiflexion of the foot. Blood clots typically occur in patients who possess some or all the risk factors for big, big child, whatever. Stasis, long flight, postoperative mobility, hypercoagulability, OCPUs, hypercoagulant states, endothelial damage, smoking, hypertension, atherosclerotic injury. Despite prophylactic anticoagulation, DVT can still occur, especially in the setting of surgery, where concern for bleeding risk often lead to a later start of therapy. The initial management of symptomatic DVT is anticoagulation to reduce clot extension and risk for pulmonary embolism. The ultimate duration of treatment depends on whether the DVT was provoked by um, identified risk factor or unprovoked, whether it is an initial venous thromboembolism or recurrent, and the patient comorbidities. Most patients will receive at least 3 to 6 months of anticoagulation. And it is not E or F because, let me see, what is it? It's not thrombectomy and TPA, also called thrombolytics, are reserved for patients who failed therapeutic anticoagulation or are suffering phlegmasia, cerulean dolens. What the hell does that mean? Because of high risk of developing compartment syndrome. Thrombectomy may be performed percutaneously or through venous resection, which is an open surgical approach. Thrombolytics have a significantly increased risk, bleeding risk, and no difference in recurrence and mortality rates compared to recommended agents. If thrombolytics are used, they can be administered systematically or directed via catheter position near the clot, catheter directed thrombolysis. Okay, so we have to do anticoagulation first, and then thrombectomy. Okay, next.
Yes.
Mhm.
57-year-old woman, sorry, 57-year-old man brought to the ED by his wife. 2 day history of progressive shortness of breath, fever, cough, productive of clear sputum. Initially, shortness of breath occurred with exertion, but now it occurs at rest. He received diagnosis of non-small cell lung cancer 1 year ago. Since then, he has had stable dyspnea with exertion. He has received chemotherapy and radiation therapy. His last course of therapy was 2 months ago. He takes no medication on arrival. He is in mild respiratory distress. Temperature is 102, pulse 104 per minute and regular. Respiration at 26 per minute, BP 146 by 74. Crackles are heard at the right lung base. Leukocyte is 16,000, segmented neutrophil 5%, bands 2%, eosinophil 1%, basophil 12%, and lymphocyte 5%. Chest X-ray increased right perihilar mass and a new right middle lobe infiltrate. Chest X-ray show increased right perihilar mass and a new right middle lobe infiltrate. Which of the following is the most likely cause of this patient's pneumonia?
Hmm.
Chest X-ray show increased perihilar mass. Is it like in the low middle lobe? Is it aspiration?
Why? What is his risk factor for aspiration?
The
We
cars.
know it's pneumonia, but what is his risk factor for aspiration? Like he's not unconscious, he doesn't drink, he doesn't have any neurologic issues, and airway obstruction secondary to carcinoma. That can be an option because he still has the perihilar
There is a
mass.
mass and new middle lobe, new
Mhm.
right middle lobe infiltrate.
It
Why
can be
middle
that.
lobe?
It
Sorry.
can be right middle lobe, overlobe, middle lobe infiltrate. It can be that, and it can impair mucus clearance. Mucus clearance. He said he's has having shortness of breath.
Let's
I
say
think it's the B. Is the what is my okay? I think it's A. Okay, ready.
yes, you were right. You,
No,
previously you were wrong. Now you were right,
no.
and I am
Okay,
wrong from the beginning.
yeah, because you don't have any risk factors for
Yes,
aspiration. This patient has pneumonia supported by his presentation with fever, tachycardia, tachypnea, leukocytosis, new pulmonary that we know. In a patient with a history of lung cancer, the most likely underlying cause for development of pneumonia is airway obstruction secondary to carcinoma. The presence of a mass results in impaired clearance of mucus, microbes, and foreign debris, which is a risk factor for development of clinically significant infection of the alveolar space and non-parenchyma. This may be caused by intrinsic compression of the airway or an intrinsic space occupying lesion in the lumen. The patient should be treated with antibiotics and non-invasive respiratory support and be monitored closely for clinical improvement. Obstructive pneumonia has a high risk of recurrence. It's not B because aspiration from recurrent laryngeal nerve compression. Huh? Wait, aspiration. What? I didn't even read the whole thing. Aspiration from recurrent laryngeal nerve compression is unlikely in this patient because nerve injury commonly results in hoarseness. Oh, okay. And it's not E because, where is E? Impaired mucus clearance is a risk factor for developing pneumonia and is associated with tobacco use, exposure to other airway irritants, conditions that cause neuromuscular weakness, anatomic deformities, genetic conditions such as Carcinoid syndrome. This patient, the presence of active malignancy and an enlarging perihilar mass are most supportive of obstructive pneumonia. Okay, next, next, next.
Yes, an 82-year-old woman comes to the physician because of 2 week history of productive cough, uh, copious amount of green sputum. She has had several similar episodes over 5 years. She has episodes of walking pneumonia as a child. She does not smoke and has a history of asthma or exposure to sick contacts. She is afebrile. The lungs are clear to auscultation. Examination show claving of the fingers. An X-ray of the chest shows streaky linear bilateral basilar scarring. Streaky linear bilateral basilar scarring. Which of the following is the most likely diagnosis? Um,
Ready?
one sec. Okay,
Okay, so the answer is
bronchiectasis.
bronchiectasis. Bronchiectasis refers to dilation and distortion of the bronchi and bronchioles that leads to obstructive lung disease. There are numerous causes, including congenital bronchiectasis caused by underlying genetic disorders of cartilage of the or the airways, cystic fibrosis and cartilage syndrome, recurrent aspiration, airway malignancies, immunodeficiency syndromes with recurrent necrotizing pulmonary infection, ABPA, allergic bronchopulmonary aspergillosis, and connective tissue disorder. Children classically present with chronic cough with or without sputum production and symptoms of infection, fever, dyspnea, pleuritic chest pain during exacerbation. Patients who were not diagnosed in childhood may report a history of recurrent pneumonia, as this patient does. Associated symptoms and physical exam findings are dependent on the underlying cause. Okay. Chest imaging may show linear atelectasis or scarring, dilated airways with thick walls, and peripheral opacities related to multifocus mucus plug. Bronchiectasis may result in progressive decline in pulmonary function if untreated and manifest as a severe COPD that limits patient activity. Lung transplantation may be required later in life. And it's not A or D. It's not alpha 1 antitrypsin deficiency presents as early panacinal emphysema and cirrhosis. It is hereditary disease resulting from misfolding of a mutated non-functional alpha 1 antitrypsin and antiprotease. The misfolded protein accumulates in the liver, causing hepatocyte damage, and is unable to prevent protease induced damage to the pulmonary parenchyma. Cystic fibrosis is an autosomal recessive disorder recessive, caused by defect in the CFTR gene. While it is associated with bronchiectasis, cystic fibrosis most commonly presents in childhood. The patient will have additional medical issues like chronic pancreatitis or pancreatitis in pancreas issues.
Okay, okay. A hospitalized 18-year-old woman is newly diagnosed asthma is evaluated 12 hour Evaluated 12 hours before discharge. On admission 2 days ago, she reported 4-month history of intermittent shortness of breath, non-productive cough, wheezing. His symptoms initially occurred only with exercise. 1 month ago, they began to occur daily with minimal exertion. During this time, her wheezing has also awakened her several times weekly. She has no other history of serious illness, takes no medication. Since admission, she has received nebulized albuterol and oral prednisolone. Received nebulized albuterol and oral prednisolone. She is alert, no difficulty speaking, repeats no shortness of breath, pulse 88, respiration 22, BP 128 by 82, pulse oximetry 2 liter minute of oxygen by nasal cannula and shows an oxygen saturation 98%. She is not using accessory muscles for respiration. There is mild scattered wheezes on expiration. Upon discharge, patient is switched from nebulized albuterol. In addition to completing the course of prednisolone begun in this hospital, which of the following is the most appropriate additional pharmacotherapy?
Ready?
Yes.
So the answer is inhaled fluticasone. This patient is transitioning from acute management of asthma exacerbation to outpatient therapy. Patients should be prescribed an inhaled bronchodilator, typically a short-acting beta agonist, such as albuterol, as needed for symptom management, and a longer-acting controller medication to reduce the frequency and severity of symptoms. Most guidelines recommend use of stepwise approach for selecting treatment based on asthma severity. The severity of asthma is determined by assessing the current degree of symptom frequency and functional impairment and is typically categorized as intermittent, mild persistent, moderate persistent, or severe persistent. These patients' daily symptoms and night awakenings are considered moderate persistent asthma, and a controller medication is recommended. For moderate persistent asthma, preferred therapy consists of a medium dose inhaled steroid such as fluticasone or a combined inhaled steroid and long-acting LABA such as inhaled salmeterol. Inhaled steroid is the most effective controlling medication, so it's included in all regimens for managing persistent asthma. Inhaled fluticasone will be the most appropriate additional pharmacotherapy to add to this patient.
Okay.
And it's not C because, sorry, C. Inhaled salmeterol is a long LABA that is utilized in combination with inhaled steroid for the treatment of moderate asthma. Prior to initiating a LABA, such as salmeterol, the patient must first be given a inhaled steroid. Okay. If the patient experiences persistent symptoms with inhaled steroid, LABA should be considered. So it's SABA, steroid, LABA for asthma. Okay.
Okay. Have you done your breakfast?